Okay. In this presentation, we're going to talk a little bit about vestibular interventions especially for hypofunction. And so when we think about vestibular rehab, BPPV is included in this. It's a portion of it, but the stuff we're going to, like I said, talk about today is more for somebody who has a hypofunction, whether it be peripheral nature, central nature. These are all the different kind of categories that we categorize the exercises are when we're doing vestibular rehab. So vestibular rehab really is the treatment of impairments of the balance system or the vestibular system through exercises. We have three main categories plus BPPV. So we have gaze stability, which is going to look more at VOR function. We have postural stability exercises, which is going to look a little bit more at your vestibular spinal tract dysfunction or motor system dysfunction. So we're going to be looking more at balance aspects. And then we have a motion sensitivity or habituation component. That's going to help to minimize their sensitivity to the movements that are making them feel dizzy. The fourth category, as I mentioned, is mechanical impairments, which is BPPV. We've already talked about those, practice those in lab, so we're not going to spend time on those today. Okay, so what are the goals of vestibular rehab? They're to promote gaze stability, which we do this through adaptation, substitution, as well as some habituation. We want to habituate symptoms so that they have decreased complaints of dizziness. We want to improve their balance and their gait, and we also want to promote mobility endurance. Many times after somebody has a patient with a vestibular dysfunction is going to not want to move. They're going to minimize their movements to decrease the complaints of dizziness and those feelings of nauseousness. And so we want to make sure that we're getting them back and active and moving again because they will decrease their endurance. So as I mentioned, there are different types. So the first one we're going to talk about is gaze stability exercises. And this is specifically looking at VOR dysfunction. One of the kind of ways that we deal with or help to work on vestibular deficits is through adaptation. So basically that is just neuroplasticity, meaning that what we do is we create a small amount of retinal slip to help increase the gain of the vestibular system. So when we do our exercises, our ×1 and our ×2 viewing exercises, which we're going to teach you in lab today, we're trying to do them so that we create just a mild retinal slip. So we're going to cause the image to either double or jump or blur or create their symptoms. We do it with just a little bit because that's what's going to help to eventually increase the gain of the VOR. So the VOR gain is basically one that when you move your eyes and your head in one direction, the eyes and the head will move in equal and opposite directions to be able to stabilize. Or when the head moves one direction, your eyes will move back in the other direction at the same speed and same distance so that you're able to stabilize your vision on whatever it is that you're looking at. So that gain should be 1 to 1. So whatever the speed is of your head turning to the left, that should be the speed of your eyes moving back to the right so that they can maintain that stability. So when we have a hypofunction, that can be diminished because of one side is not working as well. And so things are not going to function as quickly because it's not going to be reading the same intensity levels because of the hypofunction. So it causes that retinal slip. So we can actually strengthen that and improve that. And we would do that through neuroplasticity. And we'll talk a little bit more about that and how we would dose that if you're doing it specifically for trying to work on neuroplasticity and increasing the gain of the VOR. Another aspect of vestibular rehab would be substitution or compensation. So this is where we're going to use central pre-programming. We might use cervical input, saccade, smooth pursuit. We're going to teach them how to use something else other than the traditional VOR to help substitute and maintain their gaze stability. And so you may not have heard of it yet. I don't know if you've done it yet in ortho, but you'll hear about cervicogenic dizziness. And basically we have proprioceptors in our neck that can also impact how our eyes move. And it's called a cervical ocular reflex that we have. And so we can utilize that sometimes to help as a substitution. It doesn't work as quickly or as fast as the VOR, but it can still allow us to do some gaze stability just at a slower level. Okay, we're going to be talking about what types of exercises would fall underneath this category when we do lab later this week. So the other categories, so we've talked about adaptation, we've talked about substitution / compensation, and then the third one would be habituation. So these are exercises based on the premise that when the vestibular system is repeatedly exposed to a provoking stimulus, the pathological response will decrease in intensity. So the more we do something, as long as we do it mildly, eventually the brain just says, you know what, it's not earth-shattering, I don't need to focus on this so much, and it'll decrease the reactivity to that stimulus, and therefore you won't feel as dizzy. However, newest research basically suggests that gaze stabilization is improved through a combination of adaptation, substitution, and habituation. So even when we work on our VOR gain, a lot of times we are going to see strength. We're going to see some neuroplasticity occur, but we're also probably going to get some mild substitution and some habituation that actually occurs as well. So they kind of all focus together. The CPGs for unilateral or bilateral hypofunction basically says that voluntary psychotic or smooth pursuit abdomen exercises should not be offered in isolation as a gaze stabilization exercise. So if somebody's coming in, they have a hypofunction, you should not just do psychotic eye movements or just smooth pursuit exercises for that person, because it's not going to help improve their hypofunction and improve that VOR and improve their symptoms. So once again, never do saccades or smooth pursuit exercises just in isolation when you're looking at a vestibular hypofunction. Okay, so that's kind of the gaze stabilization. So we have those 3 different categories that we work on when we do gaze stabilization. We're looking at trying to get the VOR improved through adaptation. We're looking at any kind of compensation or substitution things we need to do, as well as some habituation exercises. So the other area would be postural stability. And so this is where we're going to look at, you guys have already done a lot of these, they're balance exercises, right? But when we're trying to challenge the vestibular system, we need to make sure that we're altering visual and somatosensory cues so that they're having to focus more on their vestibular system. So whenever we're doing postural stability exercises for somebody with a vestibular dysfunction, we want to remove or alter some sensory cues to force the patient to use other cues to maintain balance. We want to focus and push them to try to use their vestibular system to maintain their balance versus their vision or their somatosensory system. Level of intensity of the exercises is dictated by fall risk. So obviously you always want to keep your patient safe. And so you don't want to make the challenge so hard that they're going to constantly fall or fall very quickly. So how do we dose when we do vestibular rehabilitation exercises, especially in these categories? The expert opinion recommendations and the CPGs for, like I said, peripheral vestibular dysfunctions in the acute, subacute phase, you should be doing it 3 times a day minimum for at least 12 minutes per day. So what that means is that you're trying to do basically exercises maybe 4 minutes at a time, okay, when you're thinking about 3 times a day. But it depends. If they can't tolerate that, then you're going to break it up. They may only do it for 1 minute 6 times a day, okay? So the big thing with vestibular exercises is you need to make sure your patient is doing them daily, and we need to make sure that we're only bringing them to when the symptoms just come on a little bit. You have to stimulate the symptoms, so you got to get them to feel some type of dizziness or nausea, whatever their symptom is going to be. So we want to bring that on mildly, okay? So whatever that time frame is, then we would go ahead and stop, they would rest, and we'd have them do it again later in the day. But what I would tell you is from when we talked about for neuroplasticity, if you want to work on adaptation, you need to be doing an exercise for at least 60 seconds at a time. So I wouldn't say try to do it more than, 6 times a day at 1 minute or 2 minutes at a time. Or, like you wouldn't want to do it 12 times and do it 1 minute each necessarily. You wouldn't want to go any more than that, because you want to make sure you're getting at least 1 minute at a time when you're doing the exercises. So we'll talk about that a little bit when we do the exercises in lab. But your goal is to try to be able to do the exercise for 60 seconds when you perform it. So that might mean that you do it at lower frequencies or slower speeds so that they can do it for longer periods of time, because the only way we're going to get to that neuroplasticity and get them to adapt is if we can get them to do the exercises for longer periods of time. So going at a fast speed for 10 to 15 seconds multiple times during the day is not going to be helpful. We really want to build up that length of the time that they do the exercise and then just spread it out over the day. Okay. So if they're in acute, subacute phase, we're thinking we want at least 12 minutes of exercise per day, 7 days a week. If they're in the chronic phase, so then we're looking at probably 3 weeks plus since the initial insult, we want to be trying to do it at least 20 minutes per day. So we're looking at, once again, at least 3 times a day for 20 minutes total per day. And so when you think about it, it's not like it's tons of time that they're having to do these exercises, and they can easily break them out so that, it's doable for them. So a lot of times I'll tell them to do it 5 times a day. Only going to take them 4 minutes at a time when they do it. So it's not this huge chunk of time that they're needing to do their exercises for, okay? Things that you want to avoid or be careful of is you want to make sure that if there's a risk of bleeding or cerebral spinal fluid leak, then obviously there'd be exercises we would not want to be performing on these patients. Okay, so as far as frequency goes, overall number of recommended treatment sessions in the acute and subacute unilateral hypofunction, we're looking at once per week for 2 to 3 sessions. Okay, Now, that doesn't mean that you can't be seeing them for other things. This is looking more at the gaze stability exercises. You can still be working on balance, working on other things if they need strengthening, etc. So I don't want you to think that they can only come in once a week. If they have other things that they need to work on and other deficits, you can definitely go ahead and have them come in. But you can see where, as they're doing better, a lot of times I might start them out at 2 or 3 times a week, but then I'm going to drop them down and I may only see them 1 time a week, especially as we move into the chronic and bilateral stages, just to modify their home exercise program, because it does take time for the system to adapt. And so we need to be aware of that too. So in the chronic, if you have chronic unilateral hypofunction, typically you're going to want to be seeing them in therapy at least 1 time per week for 4 to 6 weeks. If they have bilateral hypofunction, then we're looking at 1 time per week for 6 to 8 weeks, or 8 to 12 weeks, because it's going to take longer for them to adapt with both sides being impacted. Patients that may require additional sessions, you may need to look at if they have cognitive or mobility deficits. We're obviously going to want to work on those. If they have moderate, severe symptom sensitivity, if they're taking vestibular suppressants, we need to work on getting them off of those so that we can actually really challenge them without those suppressants. So they might take a little bit more time. And once again, as I mentioned, any kind of deficits with their gait, with their balance, etc., mobility, transfers, we're going to be wanting to see them for an increased frequency to work on those things as well. So what are your discharge guidelines when you're thinking about a patient with a hypofunction? Obviously, as with any other kind of things with PT, when their goals are met, we're ready to discharge, right? When their symptoms have resolved, if they hit a plateau, patient chooses that they don't want to come back, they're not being compliant or adhering to their home exercise program, if their status deteriorates, if they have a prolonged increase in symptoms. So everything you're doing, it just continues to increase their symptoms. So we're not seeing any improvements or comorbidities that might no longer allow them to be able to participate. So those would all be reasons for discharge. I will tell you that the big thing when you're doing vestibular rehab with patients is you need to get patient buy-in, because of the fact that you're going to be challenging them, you're going to be making them get dizzy. But if they're doing them correctly, it should be mild. They shouldn't have long-term responses afterwards. So if they're doing the exercise, they shouldn't feel bad for the rest of the day. They can only do it once. So you need to make sure that you're dosing it where they can do it 3, 4, 5 times a day, and not ruin the rest of their day so that they can still function and do the things they want to do. So it becomes really important to work on the dosing with your specific patient to make sure that they can stay compliant, they start to see the changes, but they can still do what they need to do throughout the day. So patient buy-in is huge. And so just be aware of that. And we can talk more about that in lab. So that's what I have for you today. We'll be heading out and doing lab in class later this afternoon. Well, we'll end up doing lab when you guys get into class on this day. So, and we can answer any of the questions there. So